Okay, let's go ahead and get started. Welcome to Medicine Grand Rounds. Today we have the Robert and Elaine Collins Lectureship and Dr. John Kellum from the University of Pittsburgh will be giving this lecture. Dr. Michelle Chanchol, our division head of renal diseases and hypertension, will be introducing the lectureship, and then I'll be making some introductory comments about Dr. Kellum.
Thank you, David. Good afternoon, everyone, and welcome to our Collins Lectureship. This honors Robert and Elaine Collins, who provided a major gift to the Division of Nephrology in 1990. And the establishment of this endowment and proceeds really support the many academic missions of the Division of Nephrology, and obviously included a yearly visiting professorship that honors great scientists like Dr. Kellum that had a major impact in the field of nephrology. This is an opportunity to thank both Bob and Elaine for their very generous gift to our division that provide major resources to continue our academic mission. Thank you. Back to you, David.
Thanks, Michelle. These gifts are really important to the department, to the divisions, to our academic mission. And I also want to thank Robert and Elaine Collins for making this gift. Dr. John Kellum is a fitting lecturer for the Collins Lectureship. Dr. Kellum is a professor of critical care medicine and also the Department of Medicine at the University of Pittsburgh School of Medicine. He is serving as the Vice Chair of Research in the Department of Critical Care Medicine and the Director of the Center for Critical Care Nephrology. Dr. Kellum received his bachelor's degree from the University of Toledo and his MD degree from the Medical College of Ohio at Toledo. He then went on to get a master's in public health at the University of Pittsburgh School of Public Health. He completed his house staff training at the University of Rochester and also served as medical chief resident. He then did his fellowship training in critical care medicine at the University of Pittsburgh Medical Center. Dr. Kellum established his career at the University of Pittsburgh and has been promoted throughout the ranks as an assistant associate full professor and has taken on a number of leadership roles that I've identified at the University of Pittsburgh. His area of research is focused on sepsis and sepsis endotypes, as well as the relationship of these endotypes to renal failure. He has primarily used this research to understand how machine learning could contribute to our understanding of this relationship, as well as develop biomarkers for risk assessment and the development of markers for inflammatory responses. So it's a pleasure to welcome Dr. Kellum. I look forward to his comments. Please put your questions in the Q&A box and I'll moderate the discussion at the end of the presentation. Dr. Kellum.
Thank you very much, David, Michelle. This is a great honor to come virtually, as it were, and to see you. Sorry, we can't do this in person. So I'm going to speak about. Can advance my slides. If I can, I'm going to speak about acute kidney injury and focus both on what I think in terms of where we are currently and where we may be able to go in the not so distant future. And I'm going to try to provoke you a little bit into thinking about this problem in a little bit different way, and hopefully we'll save enough time at the end so we can have some questions and you can push back on any of the remarks that I'm going to make. So my disclosures are here. Recently, I've taken a leave of absence from the university, and I'm actually working for a small but publicly traded biotech company in Toronto, Canada. I've actually not been to the office yet because the border is still closed. But in March, I started working as chief medical officer for Spectral Medical. I'm not going to speak about any of the products that the company makes. But I will actually mention at least a little bit on some biomarkers that Astute Medical has developed and now wholly owned by bioMérieux. So I will comment on some of their products, and I may touch on some others in passing. So let's start with with a sort of central question: what is acute kidney injury anyway? It's really a much bigger problem, I think, than most people realize. Sometimes it's referred to as the most lethal condition that no one's heard of. Certainly the general public doesn't understand this problem, and even many of our medical colleagues don't fully understand it either. I'm not sure I fully understand it, and that's what we'll try to wrestle with a little bit today. It's defined as an abrupt loss of kidney function due to multiple causes. Some common ones are sepsis and drugs, major surgery, particularly cardiac surgery. It affects nearly 6 million people a year. And if you think about that for a second, just how in the US alone, just how staggering a number that is. Mortality is about 10%, 25% if you're in the ICU. It doubles hospital costs. So hospitals should care about it as much as doctors and patients. And it currently is defined by, somewhat crudely, I would say, by changes in serum creatinine and urine output. Here's a patient that might have acute kidney injury. This is a stock photo from the internet, but it could be a patient with acute kidney injury. Difficult to say. Even with basic laboratory tests, it's difficult to say whether this patient has acute kidney injury. And the reason why is that we use, for example, serum creatinine and urine output to monitor kidney function. And here's an example in an animal model of two scenarios that are associated with very similar increases in serum creatinine. On the top, we have serum creatinine secondary to volume depletion. And on the bottom, we have serum creatinine increasing in exactly the same way, secondary to injection of lipopolysaccharide endotoxin. But they have remarkably different effects on the kidney. On top, we have a situation from volume depletion where there's no damage to the kidney. And we can see this by looking at the tissue, or we can use, as what's shown here, a reporter assay for NGAL, a marker, a sort of a troponin, if you will, of the kidney. And there's no signal on the top, whereas there's a quite robust signal, as you can see in the bottom, particularly on the far right. The other problem, and this is some work from our lab, is that kidney injury as measured by functional change, by serum creatinine and urine output, can disappear entirely very rapidly. So this is a model in which kidney injury is produced by cecal ligation and puncture in the mouse. And you can see that creatinine rises acutely, but by 24 hours, it's virtually back to normal. Let me see if I have a pointer here. It's gone, basically. Serum creatinine is normalized by 24 hours. NGAL, that marker of kidney damage that I mentioned a moment ago in the tissue, is also gone at 24 hours. And if this were a patient, you might say, well, okay, this patient, maybe had something, but I'm not really sure it was significant, and it's all gone by 24 hours, so I'm not going to worry about it. And yet, if you look at the tissue at 14 days, there's already evidence of a fibrotic phenotype that's evolving. If this were a patient, this would be a patient who's developing chronic kidney disease from their acute kidney injury, and it's entirely invisible to us clinically. And so this brings about what I would, in a sort of shameless steal from one of our former vice presidents, I would call this an inconvenient truth that we can't recognize kidney damage clinically until it's too late. It's just the current tools that we have available make this very, very difficult, and therefore we miss and misinterpret a lot of a kidney injury in the hospital and in the clinic. And we're no better or worse than our colleagues around the world. This is data from a audit of care of patients with kidney disease or acute kidney injury in the UK, where they take this very seriously and have for several years now, much more seriously, I would say, than we have in the United States. But this audit found that only about 50% of acute kidney injury care was considered to be good by the auditors. There was poor assessment of risk factors for acute kidney injury, both in assessment of patients with established acute kidney injury and those who subsequently developed it. The auditors judged there to be an unacceptable delay, in their words, in recognizing post-admission acute kidney injury in 43% of patients. And in 1/5 of these patients, AKI was both predictable and avoidable. In the view or the opinion of the auditors, complications of acute kidney injury were missed in 13%, were avoidable in 17%, and were managed badly in 22% of cases. Now, right around the same time that audit was taking place, we were engaged in developing the first clinical practice guideline for acute kidney injury under the aegis of KDIGO, Kidney Disease Improving Global Outcomes, which is sort of an international federation of national kidney foundations. So this is an international effort to try to improve the care of patients with kidney disease. And this one was focused on acute kidney injury, and I was fortunate enough to co-chair this with my colleague Norbert Lemire in Belgium. And one of the things we did was to codify the definition, the clinical definition of acute kidney injury, which involves, and still today, involves measuring serum creatinine. And at least in the ICU, we don't do this very well outside the ICU. In fact, we don't necessarily do it all that well in the ICU, but measuring urine output. And it is urine output and creatinine together that provide the most robust measures of kidney function to allow you to stage acute kidney injury. Now, does this matter when we use this at the bedside? And the way to test this most appropriately would be to randomize physicians to use the criteria versus not use the criteria. And of course, we could never do that. Another way to do this is to provide some clinical decision support, some electronic computer clinical decision support to allow clinicians to identify acute kidney injury more easily. And the biggest target for this is that it's actually quite difficult to establish a baseline renal function. A patient comes in with an elevated creatinine and you don't know whether they have chronic kidney disease, you don't know whether they have acute kidney injury, or perhaps both. And so even with our electronic medical record systems that we have, it takes time and effort to find prior serum creatinines, to kind of eyeball them, to figure out what we think the best baseline is, and then to look at what the change is. So a computer can do this. A computer can go back into the medical record. In fact, it can pool data from multiple different medical record systems and figure out what is the most likely baseline renal function. And so that's basically what this alert does. We formed an alert at the University of Pittsburgh Medical Center. We have the advantage of having many hospitals that are upwards of 23 hospitals now using the same medical record system. And so we rolled this out across our entire network of hospitals and then began to collect some data on what it meant for patient outcomes. And the alert basically is shown here as an example saying that, a patient had a change in serum creatinine that meets the criteria and provides some guidance as to how to think about that patient in terms of their clinical assessment. And that guidance is very limited. It basically says, if you think the patient's critically ill, here's the number to consult critical care. If you think the patient needs a nephrologist, here's the number for nephrology. There wasn't an algorithm that was applied to these patients. So it's primarily what we would refer to as an informational alert. And when we looked at what effect this has using a before and after study, there are more powerful ways ways of studying this, step wedge designs and true randomized clinical trials. But the size of the effect that we expected to see from an informational alert, and in fact, the size of the effect that we found was so small. It's clinically important, as I'll show you in a minute, but it's small such that it would really be undetectable with any kind of randomized trial that we've sort of ever conducted in nephrology. And so here's the effect on patients in terms of an odds ratio of mortality, comparing before the alert was implemented to after the alert was implemented. And here's the effect on patients without acute kidney injury. And you can see there's no effect here. And there's a small but highly statistically, just because of the numbers, highly statistically significant effect in patients with AKI. And so we were able to see a change of about 0.5%, just under 1% in mortality in patients with acute kidney injury. Now, you can't control for secular trends because of the before and after design. So did the care of patients improve such that this is not related to the alert, but somehow just related to changes over time? It wasn't recapitulated in patients without acute kidney injury, however, and length of stay also changed by about 1/3 of a day, and again, didn't change in patients without AKI. And renal replacement therapy decreased, suggesting that it was an impact on more than just mortality. And although these changes are small, considering the incidence of acute kidney injury, if these results were generalizable across the entire United States, the alert could save as many as 17,000 lives and $1.2 billion annually. Now, I've tried to get my hospital to write me a check for my research based on at least a fraction of this, and so far they've not been willing to do that. But I think there are large opportunities for improvements in care and translating into savings of dollars as well for the healthcare system if we were to do this. And we followed this up with subsequent analyses, and the data are still showing a sustained effect. And in fact, if anything, mortality rates are still coming down slowly with acute kidney injury, whereas they're not changing in patients that don't have acute kidney injury. Same is true for length of stay. Again, a very small but sustained decrease over time, whereas it's flat in the patients without acute kidney injury. I also draw your attention to just the magnitude of this difference between patients with and without acute kidney injury, because I'm going to come back to that at the end. Now, of course, other things are happening in the care of these patients. We've introduced biomarkers for better and earlier assessment of these patients. But I'd like to think that the alert at least is providing some effect on overall mortality. We've also made the alert better by tweaking the sensitivity and specificity of the alert as it compares to clinically adjudicated acute kidney injury, and we have recently published on that as well. Now, if you look at actually what we do in this setting, and actually I should have mentioned that in the prior slide as well, is that one of the things that's clearly occurred over time, and we didn't see this initially, although we weren't able to necessarily look at it as well as we were in the subsequent analysis, the follow-up analysis, is that we saw a reduction in the use of nephrotoxic drugs. So vancomycin is decreasing, piperacillin and tazobactam, and the combination of these two nephrotoxic agents is decreasing. Now, I may have said something surprising to you. You may not be aware just how strong their association is between pip/tazo and acute kidney injury. You're certainly aware of vancomycin, but pip/tazo might be Zosyn might be a surprise to you. And I think that brings up, sort of the second inconvenient truth, which is that we contribute to acute kidney injury. We do it all the time. There's a lot of this that is iatrogenic. And I don't have a slide on it, but just to draw your attention to kind of another inconvenient truth as to this is just think about how much the impact, the effect, the rates of renal failure in patients with COVID have changed over the course of the pandemic. And early on in the pandemic, we had extraordinarily high rates of renal failure requiring dialysis in these patients, and it's come way down. Has the disease changed? No, it's the care that's improved. We've learned how to care for these patients better. And that's a sobering assessment of what we can do to provide better care for these patients. And this signal of piperacillin and tazobactam, which I mentioned, this is some data from our children's hospital, some work that Emily Joyce led while she was still in Pittsburgh. And you can see that there's a very strong odds ratio in favor of piperacillin being associated with acute kidney injury, whereas cefepime, which would have the same indications, if you will. So, indication bias is, of course, the big concern we have about drawing conclusions from associations, but cefepime is really a very reasonable alternative, and the indication for cefepime versus pip/tazo really are no different, and yet there's a very large difference in the odds ratio. Interestingly, at Children's Hospital, and I think this is also very telling, there is a very, very robust monitoring of vancomycin levels and dosing, much better than what we had. We have a better system now in place for the adult hospital, but back when this data were collected, Children's Hospital was definitely different. And you don't see a signal with vancomycin, interestingly enough. This is even more controversial, which is the effect of ACE inhibitors and receptor blockers on acute kidney injury. And there are even studies that have shown that when creatinine goes up slightly when these drugs are implemented, there's actually a benefit. But this is an observational study, a very large observational study, which suggests that any increase in serum creatinine is associated with harm. I'm not sure what to make of the dichotomy between this study, this observational study, and the interventional studies, other than just to mention the randomized trials, just to mention that the benefit that's been shown is really limited to very, very small increases in serum creatinine. And so when serum creatinine increases by 30% or even by 25%, we just don't see that in the clinical trials that have ascribed potential benefit. And the reason there's potential benefit is the idea is that once you use enough of an ACE inhibitor to have an effect on renal function, it's actually working, similar to heart rate coming down with the beta blocker, et cetera. But this is concerning, right? So if creatinine increases by, say, 30%, there's a very strong increase in terms of the hazard ratio associated with these particular outcomes. And in cardiac surgery is a tremendously large cause of acute kidney injury. And interestingly, there are circumstances in which both serum creatinine and urine output increase, and there's a very large increase in in what we call major adverse kidney events, which is death, composite of death, dialysis, or persistent renal dysfunction. The additional deaths in this case, the additional events in this case are due to CKD and death. There's still not that much dialysis that occurs after cardiac surgery, only about 2 or 3%, even at 12 months. But this is interesting. This is isolated oliguria, so no rise in serum creatinine at all, which happens very commonly in cardiac surgical patients. This was associated with a big increase, relatively speaking, at least, of major adverse kidney events. But the additional events in this case were due entirely to new onset CKD or worsening of CKD. There was no increase in mortality at 1 year. Now, if you were to follow these patients much longer, you may well see an increase in mortality as well, but at least in terms of 60-day follow-up, which is, I think we did 60, 90, and 180-day follow-up on these patients. So at 6 months, there was not an increase in mortality. What about something we give every day to every patient? Are you still using saline? There's quite a lot of data going back to some work that we did back in the turn of the millennium, showing a relationship between chloride load and survival in animal models, and showing that you could induce shock with just changing the acid base, producing a little hyperchloremic metabolic acidosis. We did that with hydrochloric acid in this study to avoid the confounding with the fluid loads, but the amount of chloride was similar to what we were giving with saline. And very large electronic medical record analyses. This is from some data using the Premier database of essentially 500,000 patients. And what we found was there was really no evidence that saline was superior to what we refer to as balanced fluids like lactated ringers or plasmolite or any of these. And there was, even in propensity matched cohorts, there was a significant reduction in mortality and morbidity associated with use of these more balanced fluids. And the interesting thing about this is there doesn't seem to be any particular indication for using saline. It's rare that that saline is really the best fluid for patients. But because of our habits, we tend to continue to use saline. There are now large randomized clinical trials, and this is not a patient-centered, patient-level randomization. This was a randomization either by month or by unit, depending on which of these studies. But these were both conducted at Vanderbilt Medical Center. And what this study showed, this study in the ICU showed that there was about a 1% absolute risk reduction in major adverse kidney events, which is again the composite of death, dialysis, or persistent renal dysfunction. And outside the ICU, non-critically ill patients, again, about a 1% absolute risk reduction in this composite endpoint. And together, this is nearly 30,000 patients. So, and also barely statistically significant. And some people said, well, this effect is really quite small. Yeah, but why would you want to allow a 1% increase in the events of major adverse kidney events in patients, particularly when you think about the fact that you give fluids to virtually every patient. It's almost impossible to be admitted to a hospital and not receive IV fluids. It is the most common intervention. It's more common than supplemental oxygen. And so choosing the right fluid is important. And this effect is probably greatest in patients, although the p-value for the interaction is not statistically significant, meaning that these two really, although they look different, aren't really statistically significant. Nevertheless, just the point estimate is greatest in patients with sepsis. So that's certainly a population that you'd want to avoid saline in. This is a dog that I had some years ago. She's subsequently died. In fact, the story I'm about to tell is how she died. We were on vacation. Her name is Jazz, by the way, and she was an old dog. She was a good dog, but she was 20 years old when this happened. We were on vacation in Iceland, actually, and I received a phone call from the dog sitter, and Jazz got sick and was taken to the hospital and put into the ICU. Oh, geez, okay. So call the veterinary hospital and speak to the vet, and she's, so what's going on with Jazz? And she said, well, she's very sick. She has an infection somewhere. We think it's in her teeth. She's got really bad dentition, and she's, bacteremic and septic, and she's got acute kidney injury. And I said, oh, okay. I said, well, I'm an ICU doc, so give it to me. Give it to me straight. What are you doing for her? And she said, well, giving some antibiotics. And I said, sounds good. We're giving a bit of fluid. I said, that sounds good too. Just out of curiosity, what kind of fluid are you giving her? And I swear to God, she said, we're given plasmolite. We don't use saline like you people doctors. She really said that to me. So vets have already decided that there's no rationale for giving saline. Now, patients, speaking about sepsis and acute kidney injury, this interaction is extremely important. if you develop kidney injury with sepsis, even with septic shock, your outcome is dramatically different than if you don't develop acute. In fact, it's hard to die of septic shock without acute kidney injury. The mortality rate in this study was only 6% in patients without acute kidney injury, whereas it increases to 17% with stage 1 and up to nearly 28% with stage 2 or stage 3 acute kidney injury. Which brings me to my third inconvenient truth, which is that AKI matters. It's actually in the causal pathway for morbidity and mortality. And you may say, well, wait a minute, you didn't show me that. You just showed me that there was an association, a strong association perhaps, but you just showed me an association. Well, there's very strong mechanistic data, causal data, on the effect of acute kidney injury on outcomes. Here's some animal work from our lab some years ago when Kai-Sing Bartle was with us. We produced acute kidney injury in a variety of different ways, folic acid infusion, for example. We also did this with glycerol infusion, which produces something that looks a bit like rhabdomyolysis. And AKI causes a little bit of increased neutrophil activity because it causes inflammation, and you can measure this by lung MPO. But if you then subsequently take an animal that you've produced acute kidney injury and you put that animal in an inhalation chamber, and you flood that with Pseudomonas and produce essentially Pseudomonas pneumonia, you find that actually the animal with acute kidney injury has less inflammation, less ability of their neutrophils to work. So they're actually immunosuppressed, which we know, which we've seen in prior studies. But this effect was really quite significant and resulted in much more this is colony-forming units in the lung, so much more infection, much larger bug burden, if you will, with the animals that had acute kidney injury. And we know this occurs because the neutrophil itself becomes dysfunctional as a result of acute kidney injury. And there's a variety of additional studies which have looked at why this occurs, but transmigration of PMNs is inhibited in the setting of acute kidney injury. So acute kidney injury causes immune defect, which perpetuates and makes the likelihood of sepsis higher and makes the outcome from sepsis worse. We also have data in humans, right? So we don't tend to randomize humans to harm, but sometimes that happens when we think we're randomizing them to benefit. And that's what happened in this trial of hydroxyethyl starch versus Ringer's acetate, which is the carrier for that form of hydroxyethyl starch in patients with severe sepsis. And what we found was, what these investigators found was that hydroxyethyl starch was associated with worse survival. So there was harm associated with this. And the only acute effects that occurred with hydroxyethyl starch was bleeding. And again, it's hard to see how bleeding would increase the risk of death, which began at about 30 days, and acute kidney injury. So we have a nephrotoxin producing acute kidney injury and is associated with, and here we don't have to say associated, we can say is causally, because this is a randomized controlled trial, is causally related to decreased survival in critically ill patients with sepsis. And let's not get too bogged down in the mortality is not the only thing that matters. And I learned that, as an intensivist, you sort of think about saving lives first and foremost. But the quality of these lives is important too. And I've learned this from these two individuals, among others. These are two patients that have become sort of patient advocates. Michael Weiss on the right is a retired academic dentist in London who's actually written a book about his experience with sepsis and acute kidney injury. And Leslie Meggs is developed acute kidney injury from sepsis as a child and underwent dialysis and then subsequently a kidney transplantation. And both of these individuals speak very eloquently about just how terrible it is to have acute kidney injury and chronic kidney disease. And so it's not just the mortality, but it is the life-altering effects of acute kidney injury and chronic kidney disease that people have to live with. What do we do about this? So this is from the KDIGO guideline. This is a figure that attempts to capture some of the things that we might do for acute kidney injury, but also it begins with identifying patients at high risk, because there are a lot of things that we might roll out for those patients even before they manifest acute kidney injury. And the guideline waxes philosophical for several pages about how to identify patients with high risk. It was a significant problem in 2012 when this guideline came out. There was no good way to identify and risk stratify patients. Subsequent to that, biomarkers have been developed. This is the only biomarker that's currently available in the United States, but there are others. This is goes by the trade name of NephroCheck. It's a panel of 2 biomarkers, TIMP2 and IGF-BP7, tissue inhibitor metalloproteases 2, and insulin-like growth factor binding protein 7. Now you know why it's called NephroCheck. And this biomarker panel, these are the area under the receiver operator characteristic curves compared to other biomarkers that are out there. You can see some of the more common ones, urine NGAL and KIM1 are here. This had the highest area under the receiver operator characteristic curve, and it's up into the range. It doesn't quite get to the troponin range, but it's certainly in that vicinity. And it was approved, as I said, in 2014 by the FDA. We started using it shortly thereafter. And one of the things that I want to mention about this biomarker is that it's these 2 biomarkers, these 2 molecules, are associated with a variety of different functions in the body, but they overlap in terms of cell cycle regulation. And so the TIMP2 and IGF-BP7 are both inducers of cell cycle arrest. They take the cell out of cell cycle at G1, which is just before you replicate all of your DNA. And this is a protective mechanism. It's thought to be a protective mechanism in that it prevents the cell from undergoing cell division when it might be injured, the DNA might be damaged, or there's just lack of bioenergetic resources in order to undergo cell cycle. And we can use this clinically to identify patients, as was seen in this study by Alex Zarbach, and simply implement a KDIGO bundle. Simply say, we're going to avoid nephrotoxins, we're going to manage hyperglycemia, and we're going to manage fluids and hemodynamics in patients with cardiac surgery, which is where this was done. And this is their hemodynamic optimization protocol involving stroke volume variation, cardiac index, and mean arterial pressure, something which will be familiar to anyone working in ICUs. And this resulted in a substantial reduction in the rate of acute kidney injury. It's very high, the event rate's very high to start with, because this is enriched by the biomarkers. Only about 1/3 of patients were enrolled in the trial, and the intervention resulted in a substantial reduction in both any AKI, any stage of AKI, or moderate to severe stage 2 or stage 3 acute kidney injury. And other studies have shown similar results. This is also from Germany, from Ivan Ghosh. And his intervention was to obtain a nephrology consult, to do a medication review, and to increase attention to fluid management. And what he's showing here is a reduction in length of stay associated with that intervention, again, in biomarker positive patients. Now, unfortunately, his primary endpoint was any stage of AKI, and he missed that statistically. P-value is only 0.076, but stage 2-3 AKI, which was a secondary endpoint, is statistically significantly improved, as are other measures and decreased length of stay, as I mentioned already. And Dan Engelman, who's a cardiac surgeon in Bay State in Massachusetts, has shown effectively that he's eliminated any stage 2-3 AKI in his cardiac surgical patients simply by using a biomarker and giving the patients that are biomarker positive a little bit more attention. He has kind of a SWAT team with nephrology and anesthesia that sort of swoop in on patients that are biomarker positive to provide them with some additional care. And this has resulted in substantial reductions in acute kidney injury in his cardiac surgical patients. And I have to say, and this is where I'm going to be a little bit provocative, this brings us to another inconvenient truth, which is that we're not all doing enough to stop acute kidney injury. We're not all doing enough. In fact, most of us are not doing enough. When the studies on saline came out, NBC, I had nothing to do with the Vanderbilt studies. When they were published, NBC News contacted me and said, they did the math. They said, well, look, this could mean a difference of 50 to 70,000 deaths, fewer deaths a year, and 100,000 fewer cases of kidney failure in the United States just by switching from saline to lactated ringers at no cost difference, by the way. Those drugs don't cost any different. Why are we giving saline? That was what the reporter wanted to know when she contacted me. And I really had a hard time answering that. I said, well, it's, something clinicians have, the way they were trained, and they haven't really changed. Shame on us, shame on us for not reacting to data. I think it's hard for clinicians. I mean, I think, when you look at effect sizes that are this small, clinicians immediately in their head, they sort of calculate a number needed to treat as though that were the indicator, as though this were somehow an expensive or dangerous intervention. And in a comparative effectiveness paradigm, which is what this is, it's really it's almost like a public health problem more than a medicine problem. And we need to think a bit more like, what's the public health solution? And when you think of it that way, it's obvious that you need to not use saline. You need to give patients a different fluid. And for most patients, that would be lactated ringers. If you want something that's more isotonic, you could use Plasma-Lyte. And there are some patients that wouldn't be appropriate for. So like I wouldn't give lactated ringers to neurosurgical patients, for example, because of the lower tonicity might be an issue for them. And I think that, and I say this with great amount of respect, particularly for the senior author here, and admiration for his work over time, but many of our colleagues have argued that we're actually paying too much attention to acute kidney injury. This is a study about, or an editorial about inappropriately low rates of coronary angiography in elderly individuals with renal insufficiency, because those doctors and patients are worried about the associated effects on contrast and of contrast on the kidney. And these authors have argued that the risks are pretty low. Well, they're pretty low if you use renal failure or dialysis as the endpoint. But this is what it looks like. This is acute kidney. Now, this is not contrast, and I would have to agree that contrast is a lower risk scenario. But this is what happens when you develop acute kidney injury. This is 15-year mortality, and some data we're preparing for publication. 15-year mortality post-ICU stratified by AKI and recovery status. So even if you recover your kidney injury, and the two lines here represent medical or surgical patients, which as you can see are virtually identical, having acute kidney injury substantially affects your long-term survival. And so we should be concerned about doing things that might be harmful to the kidney. Now, should we avoid doing coronary angiography in all these patients? No, in some patients, the risks of acute kidney injury are smaller than the risks of not doing the angiography. But in others, it's just the opposite. These are the number of deaths per year, official cause of death on death certificates as reported by the CDC. Heart disease, cancer kill about 600,000 patients a year. But epidemiologic studies have come to very similar numbers on AKI, about 600,000 a year. So why aren't they on the death certificates? Well, the reason for that is interesting. The This is a patient I actually took care of recently, a 59-year-old who had ovarian cancer, and she was treated with cisplatin. And her cancer was thought to be in remission, but she was sick in the hospital because she developed acute kidney injury from the cisplatin, which progressed to stage 3. She was started on dialysis. She subsequently developed MRSA sepsis and died. Do you know what was written on her death certificate? Yeah, she died of ovarian cancer. So she's in this column, not in this column. And I would argue that she really died of AKI and sepsis. She really didn't die of cancer, and that's the problem with these statistics. But patients with acute kidney injury often have other disease. They're not like myocardial infarction patients who die suddenly outside the hospital. Patients with acute kidney injury are complicated, so it's hard to compare their mortality rates with cardiac deaths. But here's one way to do that. Let's look at perioperative myocardial infarction. And in this study of 218,000 patients, the crude 30-day mortality in patients with myocardial infarction after their operation was 8.9%. And that compared to 1.5% in patients without myocardial infarction. This was published in 2018. And here's data from our study in which and this is in the supplement of the paper, in which we've broken out surgical and medical patients. I'm just showing you the surgical patients, 186,000 surgical patients, where the hospital mortality was 10.6% with acute kidney injury and 0.8% in patients without. Now, I guarantee you consult your cardiology colleagues for these patients. And I bet you don't consult nephrology for the vast majority of these patients. Why is that? Let's think about that for a second. It's a 10-fold mortality risk if you develop acute kidney injury. That's pretty serious. It's the same, in fact, it's even less in myocardial infarction. And maybe just as importantly, if not more importantly, how many of these patients see a nephrologist in follow-up? Turns out about 15% of patients with AKI see a nephrologist after discharge from the hospital. I'm being very glib here, but come on. Certainly more than 15% of patients with acute kidney injury whose risk of mortality over the next several years is quite substantially increased. Surely some of those patients would benefit from better kidney care than they're currently getting. So I would argue in conclusion that acute kidney injury is a significant looming threat. And hopefully you can sort of see this looming threat here in the background. And here we are as clinicians, I think, being overly complacent about this problem. I don't think we've given it nearly the attention it deserves. And I think our patients are suffering because of it. Now, I will tell you, there is a renalism risk here. There is a risk of going too far the other way and saying, oh my God, they've had a kidney injury, I better take them off of all their potentially nephrotoxic medication, some of which may be more important that they stay on. So I'm not suggesting that we only pay attention to the kidney. It's not that the kidney is the only important organ, but I do think we are paying less attention to this problem than we need to. And I think that we need to focus on it more than we currently are. And I think with your help, we can stop kidney attack. And with that, I want to thank you for your attention and thank my numerous colleagues around the world for their collaboration over the years. David, thank you very much.
John, that was great. Thank you. We have a lot of questions. I think I'll start out with the first, which is tell us a little bit more about mechanism. Plasma light versus lactated ringers versus saline. What's the mechanism that underlies the renal disease? And should this be generalized to all balanced crystalloids?
So great, great question, David. And the short answer is that we really don't know. When we conducted some of the animal experiments we did now 2 decades ago, and some of the other work that we've done in this space, we really were thinking that what was happening was you were delivering more chloride to the distal tubule thick ascending limb, and you were causing, by tubular manual feedback, a bit more reduction in GFR, and that's what was happening with the saline. But histologically in animals, and we don't have these data in humans, in animals, there's histologic evidence of worse damage to the kidney, to the tubular epithelial cells with saline on top of another nephrotoxic. So you can't, saline by itself isn't nephrotoxic, but it worsens nephrotoxicity in the setting of sepsis or other causes. And that's at the histologic level. It's not at, so the only mechanism we've been able to identify is that there's an increase in inflammation. It's not by much. Cytokines are increased by about 15 to 20%, but there is increased inflammation associated with the chloride load and potentially through a metabolic acidosis. Whereas lactated ringers actually experimentally is associated with decreased inflammation. So there's an interesting dichotomy there.
During my education, I was always taught that surgeons use lactated ringers and internists use saline. Talk about the cultural issues that you're facing in terms of getting people to change.
Yeah, so I think that's, that's why I was so struck by the veterinary medicine doctor who, told me, wow, we just don't do that in any of our animals. And I think pediatrics is perhaps different about it too. I think there's a lot of concern about hypotonic solutions, et cetera. The lactated ringer story is very interesting because if you go back into the 1970s, and David, you and I are not quite old enough to remember that, but we remember the era right after that. And lactated ringers had a very bad reputation because until about 1977, lactated ringers in this country was a racemic mixture of D and L-lactate. And D-lactate's toxic, at least at high concentrations. And you can get cardiac toxicity and neurotoxicity from D-lactic acid. And there was enough of it in lactated ringers that if you gave 10 liters of it, you could produce a problem. And that really kind of, people then forgot when we went away from taking we got all the D-lactate out. People forgot that, there was nothing wrong with the lactated ringers that's available now. But so I think that has, and I think you're exactly right when you call it a cultural issue. It's not medicine, it's not science, it's really anthropology that these things that we do. But it's pretty easy. I've tried to do it myself to not write for saline and instead order something else. So you can do it. You can do it.
So how should we think about the finances differently? When someone develops renal failure, not that we are promoting this at all, but when someone develops renal failure, a renal consult goes in, patients go on dialysis, the healthcare system benefits to a certain extent by the financial implications of renal failure. How should we think about this differently in terms of societal benefits and overall financing of the healthcare enterprise?
Well, so that's an interesting question to raise. And remember, I said at the beginning that I've taken a leave of absence from my hospital. So maybe I'm at liberty to say what I think about that issue, which is that, I like many of us, I like maybe all of us, I went to medical school to care for patients and not protect the hospital's pocketbook. Now, I grant you that we're all better off if the hospital is solvent. And so I do think we all have a responsibility to not waste money. But I think that's different than worrying first and foremost about the hospital's bottom line. My job as a doctor is to care for the patient. And so I think my generation has perhaps, and the generation that follows me is perhaps a little bit too focused for my taste on hospital economics. And, I think we need to focus more on what's best for the patient.
Mm-hmm. Tell us, absolutely, 100%. tell us a little bit more about how we might, maybe in closing, reframe our approach to AKI. In other words, should these individuals be moved to higher intensity forms of observation and care in the hospital to prevent the further development of renal failure and the implications of that?
I think that's one option. I think the tricky part about acute kidney injury, and I don't mean to suggest that my cardiology colleagues have an easier job, but you know, when a troponin is elevated and you have you know, 3 millimeters of elevation of the ST segment across the precordial leads, you know what to do. You're going to send the patient to the cath lab. You know, that's the intervention. There's not a lot of difficulty there. When somebody develops acute kidney injury, it's not from one cause, as it is in, you know, the vast majority of myocardial infarction. It's really coming from, you know, 4 or 5 common and a dozen or so less common causes. And so it's very challenging to figure out what's wrong with these patients and do the right thing. So there's not a simple answer for everybody. If there was, I think we would have, you know, sort of fallen on it already. So the answer is a very non-satisfactory, which is why I think biomarkers have had difficulty getting a lot of perch in the field. The answer is not so simple as to say, if it's positive, do this. The answer, unfortunately, or maybe fortunately for job security for us doctors, is that if the biomarker is positive or the patient develops AKI, you have to then go be a doctor and you have to figure out what the best care for that patient is. Sometimes it's about getting rid of a nephrotoxic drug that you didn't think was the cause, but it turns out that it is. Sometimes it's about finding an undrained fluid collection, which is causing sepsis and you haven't addressed it. Sometimes it's about treating heart failure that you didn't think was there, and it turns out that it is. And sometimes it's about some rare cause of acute kidney injury. Acute kidney injury is so common that you're going to find cases of glomerulonephritis, for example, in places that you don't expect to see it. And so bringing in your nephrology colleagues to help with that early on. And yes, David, I do agree that there are patients that you know, belong in an ICU. We recently wrote a paper, I think it just got published, about the use of AKI biomarkers to identify sepsis earlier, because AKI is the most common manifestation of sepsis, or one of the most common manifestations. And if you can identify it earlier in your patient who you thought just had infection, it turns out they have sepsis, you might be wanting to send that patient to the ICU. And interestingly, that population that was missed initially as having sepsis actually had a higher mortality than the patients that were identified as having sepsis. So I think there are all kinds of opportunities for better care in these patients. So I think that, you know, if I leave, you know, this discussion with anything, my sense is, and you know, in the discussions I've had with faculty here, I think you guys have a lot of really good ideas about how to address that. So I think there are some opportunities that can be capitalized on.
Well, thank you so much, John, for sharing your ideas with us. This has been an important wake-up call for us, and a lot of lessons learned. Great work that you're doing. Keep it up.
Thank you.
Thank you.